that is some good water. Water. We need it. It is a basic human need, essential to all forms of life. However, today we're not really talking about water. We're talking about the elimination of water and maybe some other things that we ingest and put into our body. How does it happen? What do you do if you have a problem with the elimination system? It's cool. It's cool, man. I'm actually going to share with you how to troubleshoot all of these problems that you may be running into. I do have my notes situated right above, so I will be glancing at them frequently. I would like to first just remind you, you need my video and the slide presentations that I shared with you to the side. That would help you figure out exactly what I'm referencing. All right, you ready to go? Because I'm ready. Hope you're ready. All right, thanks, Freddie. Slide 2. Well, we refer to going to the restroom or peeing as voiding. You'll hear void used actually more frequently than the other words such as micturate. Ugh. In fact, let's not use that in front of the patient because they won't have any idea what you're talking about. So we can say urination, urinating, how many times have you voided? That's more of the appropriate terms for you. You have got a muscle that actually lines your bladder and it stays relaxed as the bladder is filling, and then from the brain comes the signal it's time to pee, and it squeezes down like it's saying I'm way too full, get rid of this urine. The thing is that you have two sphincters, the internal sphincter that's right at the neck of the bladder and the external one. What do you think that one is? Probably at the external. Yes, it's right by the outside of the body. The thing is those must be pretty darn strong to hold urine against the two, to hold urine against the muscle activity of the bladder. So, normal sequence is bladder gets full, send the signal, hey, I'm going to start squeezing, you better release. The brain can send the signal back down and says, hey, this is a good place, go ahead and I'll open up the sphincter, you squeeze. It's a coordinated function. If we don't have that coordination, we have some problems. And medication interferes with any parts of those pathways. But a lot of times it's the conscious relaxation of the sphincter which allows you to experience the effect. Yes. All right, slide 3. This is a basic anatomy or anatomical list of organs that are involved. So I am not going to go over those just because it is something that you usually bring to the table, basic knowledge of the urinary system. The bladder is a muscle, the urethra is usually shorter on females, longer on males. The ureters connect the kidneys all the way down to the bladder, and they're connected onto the bottom of the bladder, not the top, on the very bottom. And just some other terms such as glomerular filtration rate. Normally, we should have a high glomerular filtration rate. This means that your filters are really, really active and they're getting out all of the metabolic waste and keeping in the fluids and the good electrolytes that your body needs, and helping with the pH balance too. So just kind of refresh yourself on it, but I am not going to go into detail explaining this to you. So, because I care about what does a nurse do. All right, slide 4. This is just very basic, promoting normal urination. Well, most people, it kind of depends upon the age and the culture that they grew up in, but we want to provide privacy. It is normal to have this be a very private thing. In fact, you must take this nonchalant approach. Sir, it's time to urinate. Here's your urinal. There you go. There is nothing more awkward than you asking, do I need to turn around? Is it okay if I stay in here while you pee? Like, don't make it awkward. You're a professional. Here's your urinal. Time to go. Or let me get you to the bedside commode. I'm going to stay in here for your safety. Don't ask. Just tell. So provide privacy as much as possible. Make sure your visitors exit the room, and sometimes I don't even ask, is it okay if grandma stays? No, I just say, Grandma, would you like to step out while he's using your restroom? And if grandpa wants grandma to stay, he's going to say, yeah, she's okay. Usually by that age, they're fine with all bodily functions in front of each other. But anyway, assist with positioning. Gentlemen, you are more likely going to feel better to pee if you're what? Lying down flat? No. Stand up. In fact, some of my patients will not be able to urinate unless they're standing up. Men-wise, talking about guys. For females, bedpans are a little bit embarrassing, but if they have some kind of mobility restriction, it's okay. You know, roll them over to the bedpan and sit their head up to a semi-Fowler's position. Facilitating toilet routines. Most patients void upon awakening, after meals, after large volumes of fluids. Like if you were to give them an IV fluid bolus, don't act surprised when they call you and they say, I need to use the restroom. It should be like, I'm going to plan on them asking me, so I'm going to go ahead probably and just schedule a time to go in the room. And most people void before bedtime. All right, I think that's all I have for that one. Let's go to slide 5. Normal versus abnormal patterns. So you've recognized the normal patterns of going to the restroom. How about, I probably voided like 20 times today. That should ring a bell in your head as, whoa, that's actually a lot. Normal's like 8 to 10. Evaluate yourself. How often do you use the restroom? Probably more like 5 to 7, maybe. So that should tell you you're not drinking enough. Just saying. Characteristics. Urine is normally a pale to maybe an amber color. It should not be bloody. It has a kind of an ammonia smell, but we should not have a pungent smell that makes your nose hairs curl. That's considered outside the normal range. Clarity, it should usually be clear. It can have a bit of a turbulent appearance. Say somebody's not drinking enough, they're a little dehydrated, so it will be amber and kind of, I hate to use this word, swirly type of look to it, thickness, but that's turbulent. But it should not be cloudy. Cloudy is not good. Or opaque. Ugh. Ugh. We should never have blood in the urine. That's called hematuria. Even if you have a little bit of blood, it might be like a pink color. Maybe it could be associated with UTI, urinary tract infection. But no blood should ever be in the urine. Okay, that would be your typical urinary elimination. Let's go to slide 6, developmental factors. Oh my goodness, if you've ever had a newborn before, just expect it. You're going to be changing a diaper probably 12 times a day, maybe. Infants all the way up to toddlers have, poor or absent control of the urinary sphincter. A lot of times our 18-month-old to 36-month-old toddler, we will start introducing them to the routines of going to the potty. It's basic toilet training happens at this point. But I will say it is highly individualized, and just because a 2-year-old is, a 24-month-old is not potty trained, it doesn't mean anything. There's nothing wrong with your kid. It just doesn't want to use the toilet and likes the diaper. So when we look at children, there are a few problems that they experience, particularly enuresis. That's just peeing at any point in time. Many a times enuresis in a early school-age child happens just because they get intensely involved in like a game, a test, or they're just so absorbed in activity and they wet their pants because they totally ignore the signal to go. Doesn't mean that they have a problem or that they're totally regressing. It's just, it happens. School-age kids pee on themselves from time to time. Now, if you're an adult, maybe not so much. Nocturnal enuresis, bedwetting at night. Girls don't have as much of a problem with this. Boys, yes. In fact, 8% of boys still wet the bed until they're up to 10 years old. So, and it's just normal. The sleep patterns, they sleep too deep. A lot of times you can use a bed alarm, which we can talk about in a little bit, but there's nothing much to this. It happens. Primary nocturnal enuresis is bedwetting in a child who is not primarily trained to be consistently dry at night. Nothing, abnormal about that one. Secondary is when you have a child who has been trained to not wet the bed, and then they wet the bed occasionally. Once again, not anything too crazy that you need to put the kid on medication for at this point. Maybe restrict fluids. In my personal opinion, the bed alarm is just cruel. It's a pad that you put on your bed, and it senses whenever it gets wet, and so it lets off a pretty nasty alarm that will wake you and your kid up. So I see that more of like a negative feedback type of behavioral change. Okay, sorry. Slide 7. Older adults. Kidney function decreases. In fact, this is a major concern of our older adults, is this change here, because their glomerular filtration rate, those little filters, it declines just naturally with age. And then on top of that, we're giving them more medications. We're giving them, a lot of, actually, let me back it up. We're giving them more medications, and a lot of times they decrease their fluid intake. So they're kind of having a twofold punch to the kidneys. So we're always concerned with our older adults and their elimination. That is a very, very common question that we ask of them. Let's see, not to mention that they start having problems with the elasticity and the muscle strength. Throw in there a few kids and you've got a real mess on your hands when it talks about, or when you're thinking about bladder control. And let's see, chronic diseases that affect the kidneys. I'm particularly thinking of diabetes, and for guys, BPH, which is benign prostatic hypertrophy, fancy for enlarged prostate. That's always a problem that we're going to be discussing with patients in terms of how it affects their urination. And for females, menopause. Menopause is up there on the list. You know why? Menopause causes vaginal dryness, and it actually, the flora changes whenever you have a dry vaginal area, and you'll actually have lots of UTIs if you don't have the normal protective flora down there. So just put that in the back of your head. Slide. All right, slide 8. Factors that affect urinary elimination. Well, let's have a little story time. Here you've got Mrs. Cow. Mrs. Cow is rooming with Mrs. Horse. How cool do you think Miss Cow is going to be trying to urinate in front of Mrs. Horse? Probably not going to feel comfortable and maybe a little anxious. I mean, it's not normal. So expect and anticipate and provide privacy to the female or to the male or to the cow who needs to urinate. So it can be anxiety producing. And have you ever tried to use a bedpan? Have you? No? Okay, see? No? Not comfortable. Sociocultural. Sometimes a patient may ask to have somebody of the same gender. So a female patient may want to ask for a female nurse. It's not a problem. We just have to accommodate them and acknowledge that they have a specific need for their time avoiding, I guess. Nutrition. So there are a few things that heavily affect the urinary system. Alcohol, maybe? Yes, absolutely. In fact, what alcohol does is it suppresses the antidiuretic hormone, which is the don't pee hormone, the hormone that gets released to tell your body, don't do it. And we will actually have the suppression of that, and a whole lot of urine just, freely be released from the body. So alcohol is a factor. Caffeine is a factor. Tea, cola, all of those contain caffeine. What if I get decaffeinated tea? You're still going to pee. Maybe not as much, but you're still going to pee. So don't pull that on me. Then diuretics, medication. There's, that's also to be factored in. There is another thing that affects fluid, and that would actually be salt when we talk about nutrition. Somebody who eats a lot of salt will experience less urinary elimination. Water loves salt. Salt's in your bloodstream. It's not going to peed out, but that's what happens. Hydration. If we have somebody who's vigorously exercising, the body is losing, lots of liquid through the skin, through sweating. That's probably something that you've never heard of before. Thank you, Miss Tonus, and you're welcome. But you're not going to have a lot of urinary elimination. The body's going to hang on to it because it's getting a little on the dry side. Last but not least, anesthesia and surgery. Obviously, surgical manipulation can affect the urinary system, but more so, I would like you to focus on general anesthesia. The drugs that they give you can actually cause urinary retention. That's the body's response. So, person comes out of surgery, just had the leg operated on, and sir, you can go home if you pee. We ask that question quite frequently, and that's actually one of the requirements to be discharged whenever you guys get to that point. Person can't pee because of those drugs in their system, so a lot of times we will hold them over a night until medicine wears out, the general anesthesia is out of their system, and then they go take care of business. What do you do in the meantime to get all of the urine out of their bladder? You cath them. That was a correct answer if you said that. Slide 9. Medications, pretty much all of them are renally excreted. The other half are metabolized by your liver. So if we have a kidney impairment, that's usually a problem. But for now, let's just talk about some of the medications that affect the urinary system. So antibiotics, particular class that are nephrotoxic are your mycins. We call those aminoglycosides. So like gentamicin would be nephrotoxic. Anticholinergics. These actually prevent somebody to relax their detrusor muscle, and that is actually a desired effect in some patients, not desired effect in others. But anticholinergic drugs, antihistamines are actually a type of anticholinergic drugs, believe it or not. You have antidepressants, that affects the urinary system. And what else do I want to say? Estrogen, I mentioned that one for the people who have menopause. We will actually give you estrogen, not because you can't eliminate urine, but because of your risk for UTIs. And sometimes for people who have an overactive bladder, the medication we're going to give you is Botox. We'll inject it right into your bladder. How do you like that one? Okay. Next slide, slide 10. More factors that affect urinary elimination. Bladder and kidneys infections. We really go into this when you get to PCC2, so I'll just kind of glaze over, but if you get a kidney stone, how do you think it would affect the urinary elimination system? Probably obstruct it. Yes, correct. For guys, we have the BPH that I mentioned, benign prostatic hypertrophy. Cancer could actually affect it. That could be obstructive as well, with the flow of urine not being able to get out. Then you've got cardiovascular and metabolic disorders. This is because, say, high blood pressure in the kidneys, what happens there is you have such a a strong force of, forcing this blood through these itty bitty little delicate filters that a lot of times it will damage the kidneys if it's constant all the time. So they do call high blood pressure the silent killer for a reason. But for another thing to think of is maybe a spinal cord injury that doesn't allow and permit the signal of either go to the bathroom or it's time to release the urine, if that's severed for one reason or the other. Okay, mobility problems. This interferes with the person's ability to get to the restroom. Oftentimes you'll find that it's not somebody has an incontinent problem, it's just they are too old, too arthritic to get to the restroom, so they'll wear incontinence pads for that reason, because they're not fast enough. We can fix that. Bladder training program, exercise. But for now. Cognitive changes. Somebody who has a psychiatric condition, maybe schizophrenia, is less aware of the environment and the signals that their body is trying to give them. They may be more conscious or wrapped up in their own ideations and their perceptions of something else. They're, not in tune with reality. And somebody may have, say, a stroke and have that neurological disconnect of, hey, I'm losing urine, I need to go to the bathroom, or I need to get clean. All right, or Alzheimer's. That's another alteration in cognition up there on the list. Slide 11. All right, so what I think would be very beneficial for you is on slide 11, we have the urinary tract infection, urinary retention, urinary continence, and urinary diversion, aka urostomy. What would be really beneficial is that you combine how your book discusses all this information onto kind of one little, not sheet of paper, but maybe like a mind map, also known as a concept map. So you would put urinary tract in the center, and then out from it, you would branch the risk factors for it. Also, you would put the recognition, which would also be known as signs and symptoms. How do you know you have a urinary tract infection? What does that look like? What does it sound like? Then also the treatment, which includes, teachings for prevention, nursing interventions. So you should have kind of like at least 4 arms off the center bubble. And I recommend that because the book is a bit scattered in how it conveys all this information to you. So I've tried to organize the slides accordingly. It doesn't go in sequence with the book because of course, I'm just smarter than them. That's how I've organized it, and that's why I feel this is better. No, they talk all about the risk factors for those things that I've discussed, and then they talk about the prevention, and then they talk about the treatment, all of them. I can see how they laid it out, but it would just be better to do one bubble, branch out. Urinary tract infections. Let's begin talking with that one. Slide 12, please. All right, so some of the risk factors for a urinary tract infection: sexually active females. Why not sexually active males? Well, one of the reasons is the distance and the urinary tract length. Guides is longer, goals is shorter, and certain, locations of other, how do I put this? The location of the rectum and anus to the vaginal area to where the urethra meatus is really close in proximity, in certain sexual positions, particularly the one where the male is positioned behind the female will actually bring the bacteria such as E. coli, which is fine in the colon area, to the urinary meatus, which is not fine in that area. It's supposed to be, without that kind of microorganism. So, sexually active females. Second thing I have there is women who use spermicide. Spermicide is actually not a positive thing because it actually changes the flora of the vaginal environment and makes you more prone to have a UTI. Normal flora is good. It's a good thing. Leave it there. We've got pregnant women. This is related to not only the anatomical changes, but the hormonal changes that occur in pregnancy. Older females, particularly those who have, menopause. I mentioned, let's see, 6 or 7. Which one am I on? BPH, that's one. Indwelling catheters, that's actually probably number one reason for having a UTI. And then the last one would be history of UTIs. Sometimes, no matter you do everything just right, and you will still have UTIs. It's a hereditary genetic thing. Your body just doesn't produce what it needs to fight off infection. Not so much immunocompromised, that's a different category. But you're more susceptible to certain bacteria. Yeah, that's better. All right, recognition. How are you going to know? How am I going to know if I got a UTI? Do I just wake up like I'm feeling kind of UTI today? No. In fact, they're going to have very specific things. In fact, the classic signs and symptoms, I don't have them listed up there. Let me fill in your blank first, and then I'll clarify which ones are your classic. So, blank 2 there is bladder spasms. It is actually quite painful. You will urinate and you'll feel like you can't get your bladder empty, and then next thing you know, like you'll have this kind of I'm not going to say electric, but gnawing pain in the pelvic region. That would be a bladder spasm. And patients can also have radiating back pain, like in their lower pelvic area. They will have a sense of urgency, like, I just peed, I know, but I need to go right now or I'm going to wet my pants. Like, my bladder is so full. And they'll sit in the toilet and go like a few drips and have the bladder pain all over again, or bladder spasms. If they have chills, that might mean that it's a little bit more systemic versus a localized infection, but they can have chills. That's a little bit more maybe advanced of a UTI. Foul smelling urine, I believe that's number 6. So urine should have an ammonia type of smell, not foul. It will hit you in the nose. You'll know it when you smell it. Hematuria, remember how I mentioned you are not supposed to have blood in the urine? With a UTI, you'll actually start seeing blood in the urine. It's not indicative if I see blood, that means you have a UTI. Sometimes there could be another cause like trauma or something like that, or kidney failure, but you will have hematuria. I think number 10 would be nausea, vomiting. You can throw up from having the kidney infection, UTI. Pyuria, that's P-Y-U-R-I-A, pyuria, that's pus in the urine. And you'll have urinary frequency. That's their last one there. So where we normally go, what I say, 8 to 10 times a day, you'll be going like 20 times a day. That's too much. So classic signs and symptoms of a UTI would be white blood cells in the urine. They usually don't stay there. Dysuria, which is pain upon urination or trouble urinating. Urgency and frequency. So those are the classic signs. White blood cells, pyuria, dysuria, urgency, and frequency. Now in our older people, they're probably not going to have all of those symptoms, and they may be even more so dull. Older people don't respond as well, to an infectious process. So their body doesn't respond like a younger person is. It's because the immune system has actually gotten a little weaker. So what are the treatments for UTIs? Well, we need to get them on antibiotics and remove the catheter. There's going to be a lot of teaching that we'll go over in just a second. But the treatment is remove the catheter and remove it hopefully permanently. You may have to just remove and replace. But get them on some antibiotics. All right. Complications. Well, you can kind of just memorize those. Drug resistance, that's always a good one. All right, slide 13 is a clicker question. What are the classic signs and symptoms of UTI? Give you a second to think. Did you think of what you wanted? All right. The answer is A. Urinary white blood cells, pyuria, painful urination, also known as dysuria, urgency, and urinary frequency. Awesome. Awesome, awesome. All right, slide 14. We're going to talk a little bit about urinary retention. So, why would somebody not be able to pee? Well, there could be a physical obstruction. Either they had radiation to the pelvic area, and scar tissue sometimes is the result of radiation to that area, so there could be scar tissue. They could have BPH, as I mentioned. They could have medications that they're on. That's block number 2. Medications such as antihistamines. They can have neurological problems such as a spinal cord injury. Number 4 would be 2 more drug classes: anticholinergics and antispasmodics, such as like, oh, don't forget it. It's a really common one. Flexeril. That could actually cause you not to pee. And then number 5 there would be tricyclic antidepressants. So yes, those are some of the risk factors that stop you from peeing. Now, what would that look like in a patient? What are the signs and symptoms of not being able to void? That your bladder's so big. How would I know? Well, your patient's probably going to get restless, especially for your nonverbal patients. They will, start climbing out of bed, start acting up. Something just happens to those patients who can't communicate. They get uncomfortable and they get antsy, agitated, so they get restless. Their urine output, 0. In fact, you'll look at your intake and output and you'll say, "Where's all my pee?" And more than likely, it's still in the patient. Either in the bladder or still in the bloodstream. Or your tech's not writing it down. Yeah. But there's no urine output. Their blood pressure may even be elevated, actually. They're going to have pain. Where? In the pelvic area, absolutely. And sometimes they'll have overflow incontinence where their bladder is so big because the bladder is retaining it, the sphincter is not letting it out, or maybe there's an obstruction. You can push and you'll see a little bit of leakage come out. That's indicating to you that you have urinary retention. You've got to get the pee out. So, what can you do? Well, I mentioned there's a few more things you can do to recognize it. More like just to assess. Besides palpating the bladder, you can do a bladder scan. That's where you use ultrasound and you kind of put it over the, right above the symphysis pubis, and hit a little button and it will tell you exactly how many milliliters are sitting in there. A person could also have a weak or dribbling urine stream. So that's how you know that they have some kind of obstruction. So how are you going to treat this person? Well, besides monitoring eyes and nose, you're going to look for the risk factors. Do they have any of those? Yes or no? You can apply heat to the lower abdomen. Sometimes that actually helps. Not direct heat, just with a cloth in between. You can do a sitz bath. For females, you can actually pour warm water over the perineum, or there's this little device you hook up to the toilet and it's connected to your sink, and it will flush warm water up in the perineum area, and it just kind of drains into the toilet. Treatment, catheterization, that's probably your most easy way to help get the urine out. Most invasive, though. There's a lot of risk associated with that because of the opportunity to introduce bacteria. So, to cath or not to cath? That is the question. Usually do non-invasive stuff first, such as what we're talking about here. When they do try to pee, we're going to grab a post-residual void. How do you do this? You grab your bladder scanner, and then you scan them again. You scan them before they pee, and you scan them after they pee. Usually the doctor will give you a number. If greater than 100, place a indwelling catheter or straight cath them. They'll give you kind of a guideline to do, and every doctor's different. but 100 is kind of the cutoff. Because remember, how much does our bladder hold? 200-ish? Yes. About 450? Yes. We can give them, because we remember on the risk factor side is anticholinergics, we can actually give them a cholinergic to help them pee, such as bethenacol or uricoline's the same thing. But this is actually a cool drug that will help their prostate open up and urine come out. Another drug that we think of often is Flomax or tamsulosin. This also helps the urine come on out a little bit easier. But for guys, that's what we give them. For girls, we'll give them bethenacol or uricoline. Uricoline's easier for me to remember because I think it's a cholinergic bed. I got the colies going on. Slide 15. Boop. Urinary retention. There's a lot of pictures up there. The first and the second picture you see on the top, both with a blue background, that is actually a straight urinary catheter kit. We will learn a little bit more about those when you go to PCC 2 with me. But for now, I just want you to at least know what they look like. So the straight cath, single lumen catheter goes in. You have to do this sterilely. It is not clean technique. And it does temporarily relieve bladder distension. And sometimes you'll even push on the bladder to help all of the urine get out. There is the indwelling catheter, which you see two types there. The one in the center, which is kind of the sagittal plane there, that would be a catheter that is held in place in the neck of the bladder with a balloon. And as you see, our gentleman has something coming out right below his belly button. That is the same type of catheter, but it is going through the cutaneous area, through his bladder from the front abdominal wall, and we call that a suprapubic catheter. Sometimes when we have such bad obstructions down in the lower area, the lower urinary tract, they just go straight into the bladder. The size, it's all dependent upon the situation. The supplies, it's all done through sterile technique. For special considerations, you want to explain the reason why you're doing what you're doing, the length of time, and the sensation that they're going to feel. It's generally not painful. They'll feel pressure more than anything. Unless this is like the third or fourth time that they've had it, and it will feel very irritated as that catheter is sliding in. Let's see, the next one is ensure privacy, offer to answer questions, and use the correct position. For guys, you can lay them down, maybe sit them up just a little bit, but usually lay them down, knees flat, like on the bed. And then for females, the dorsal recumbent, so they're on their back, their knees are up. And then if they're obese and you're not able to get to the labia, you turn them on the side and you just lift up the cheeks. The buttocks is the proper word. All right, slide 16. You're managing urinary retention. So, I've got the catheter, now what? Well, you are going to have to make sure that whole system stays closed. Not where you drain the urine, that's safe to open, but you're not going to disconnect that latex rubber piece from the clear plastic tube. Always keep it a closed system. This keeps it clean, less opportunities for bacteria to be introduced into the bladder. Prevent backflow of urine. The patient here, urinary bag should be here. If you have it up here, gravity is going to tell you that the urine is not going to flow from the patient down into the bag. It must always be lower than the patient. Must. No dependent loops in the whole system. In fact, a lot of times if the patient is here, they will take the tube and wrap it on the bed and then it will go straight down. Not this, it hangs off the bed and then it goes up into the bag. Dependent loop. Bad. Maintain skin integrity and mucosal integrity. You should be kind of doing pericare about every 12 hours. That's pretty standard. Bladder irrigation, this is if they have that chunky of urine, you may have to irrigate it. Other times they may have blood clots in their urine and you've only got one itty bitty little tube, and those clots can get quite big. So you'll actually use just sterile saline to flush up in there. Let's see, removal of the indwelling catheter. So when this is done, you must clean the whole area first, just regular soap and water or those wipes. So clean it. Tell your patient to notify you of the first void. That's the second little step there. When they do void, they need to do it within like 6 hours of the time that you pull the catheter. So if it's 12 o'clock and the person has it voided within 6 hours, it's time to scan them again. For whatever reason, you're holding on to the urine. We may have to recath you. Step number 3 is note the time that they pee and the color. Very important. And then number 4, compare the ins and outs of the patient for the next 8 to 12 hours. Because they could possibly, when you pull that catheter out, have edema that sets in, and that's a problem. So they need to be voiding consistently. All right, slide 17, managing urinary incontinence. So this is problem number 2, dose. Some of the risk factors there. Females, just being a female makes you more at risk to urinary incontinence, and the reason being is the childbirth, and it's females related to childbirth. I should probably put all that together. They stretch out those muscles down there that support all of the pelvic organs. Older age actually puts you at more at risk for urinary incontinence. It is not a normal part of aging, such as you get old, you're going to wet your pants. It can happen. A lot of older adults won't seek care because they think it's just, normal, but we see more incidents, I guess, of urinary incontinence with older age. But neurological disease, that one's up there. Obesity, actually. The sedentary lifestyle. Depression makes you more prone to have urinary incontinence. Diabetes, BPH. In fact, that is the most popular reason for men, so you can have retention and incontinence. Smoking cigarettes. Hey, I wet my pants. Yep, if I help put 2 and 2 together for you with that demonstration, perfect. Smoking cigarettes. Recognition. Boy, there is a bunch of types of incontinence. Do I have to know all these, Ms. Tonis? Yes, actually, because if you know what type, you can actually give a person very specific teaching on how to fix it. So, in a nutshell, urge incontinence. This is whenever you have overactive bladder. This is when you lose large amounts of urine all at once, 20 times a day. A lot of these patients can take a anticholinergic drug such as oxybutynin. There you go. It's sold over the counter, and this is only for overactive bladder or urge incontinence. It doesn't help with any other types of incontinence, but the bladder is just kind of spazzing throughout the day and people pee. All right, stress incontinence. This happens when you lose small amounts of urine, and it's related to abdominal pressure, laughing, coughing, sneezing, lifting something, any type of activity that involves, a grunting, or not grunting. The use of abdominal muscles will just kind of squeeze a little bit of urine out. And this is very common in females after a baby. Then you have mixed incontinence, which is kind of both stress and urge incontinence together. So you'll have both. How do you determine if a patient has one or the other? Well, interview them, and through your questions you can determine if they have one or the other. Excuse me. There is overflow incontinence. This happens in our males who have the distended bladder, so the urine gets so full, gets such a high volume in there, either the prostate, or they can even have a fecal impaction that the person will start leaking little bits of urine there. We call it overflow incontinence. We have functional incontinence. Well, This is the loss of urine with no particular cause, maybe immobility, maybe pain, external problems, maybe in thinking or communicating that prevents somebody from reaching the toilet. But, you know, Grandpa wet his pants for no particular reason. Functional incontinence. They do have the function, is what I'm trying to say, normally. There's the reflex incontinence. This is when a person doesn't realize that their bladder is full, maybe to central nervous problems, you know, but they do so in a very predictable, you know, pattern and rate. It could be because they had radiation to the area, cystitis, bladder inflammation, but this is called reflex incontinence. Then we have the enuresis in adults. This is, you know, maybe familial, runs in the family. It could be related to stress, allergies, good hearty laugh. You know, the cause is not really apparent, but they'll just have a full wetting right there. Nocturnal enuresis, you know, once again, it can persist till age 10. It's genetic, so it kind of runs in the family. Kids can outgrow it. Small number have secondary type of enuresis, but medical conditions can also cause it too, such as diabetes or extreme constipation. There we go. Couldn't get it out. Slide 18. Treatment and management of urinary incontinence. Well, first thing you're going to do is manage their skin, because this is probably the number one thing that is going to cause a problem from them, is their skin breakdown, and then you get infections, and then you get bed sores. So we are going to you know, keep the skin, the clothing, and the bedding clean and dry, especially after any type of leakage, a little bit or a lot. Barrier creams are very important. You can even use antifungal powders, because they might have like an excoriated area on their buttocks, and you use something such as nystatin to eliminate the fungal growth that happens. Absorbent products, don't put a towel down there. A lot of your older people may have financial difficulties, say paying for those pads, because they are expensive, so they'll use a towel or you know, just a little rag. You know, if that be the case and they cannot get it, they just need to change those out very frequently, because their skin, if not, will break down. Okay, lifestyle modifications. Ooh, remember this? Smoking, yes, all right. Let's stop smoking, because this causes a problem with the continence. Also, how about the alcohol? Absolutely. Alcohol and caffeine beverages. Let's limit, or if we can, omit the intake of that, and you will have much, much better urinary control, people. We do not want to restrict their fluids. I mean, yes, if it's greater than like 3,000 milliliters a day, okay, you're a little bit over. It's not matching your lifestyle. You're unnecessarily drinking that much, because we need 2 to 3,000 is kind of your goal. So, but generally, for somebody who has urinary incontinence, you're not going to limit their fluids. Let me say it again. For somebody who has urinary incontinence, you're not going to limit their fluids. Is that right? Yes. Good. See? He understands. We can do bladder training. The goal of bladder training is to enable the patient to hold increasingly you know, growing and larger and larger amounts of volume. So we will pee every hour, couple of days, pee every 2 hours, every couple of days, and then you just keep growing until a person can actually hold it successfully in between those time periods. Good. So schedule voiding. And then they need to create a voiding diary. So I wet my pants 2 times today versus 5. This actually kind of reinforces to them that they are, you know, improving and they're doing a good job. Good job. Good job. Ever had to pee and you're walking to the bathroom and the urge grows and grows and you start running to the bathroom, you feel like you're just gonna wet your pants? We actually are going to tell our patients to stop, and if you're that person, stop. Do not let that urge control you. You get control of the urge, and then once you feel that you're not going to wet your pants in that moment, then proceed to the bathroom. So it's actually a mental thing as much as it is a physical thing. That's a really big technique, actually. You can try it someday, just on yourself. Kegel exercises, most commonly used method for preventing and reserving incontinence in women for the first year after giving birth. In fact, in Europe, females, once they have their baby, won't actually stay in the room all day and hang out. They will, like 4 or 5 times a day, go down to a special room where all of the mothers are there and all the babies are up with the nurses, and the moms will practice Kegel exercises together. It's that important, and it is. We don't exactly value or do that here in America, but it is something to consider if you ever become a mother-baby nurse. Have you practiced your Kegel exercise today? And you can do it now. I just did mine. Not really, but all right. Improvement rates for Kegel exercises vary from 48% to 80%. So if you have a lot of urine loss, you can actually improve by up to 80% by doing those Kegels. That's something to talk about. So do you see those pictures? Those would actually be pictures of vaginal weights. Yes. They are increasing in certain weight measurements, and so you would start off with a small one, and a female would have to carry it actually to increase the pelvic floor muscles. You cannot do this with males, only females, and it will help with the urinary incontinence because you strengthen the muscles. Biofeedback, that's whenever they attach these little receptors to inside the vaginal wall and kind of around the anal area, and a person squeezes and they can see how high they're squeezing, and it actually is a physical therapist or even a technician who will set goals, and so somebody will squeeze according to how high the goal is set, and they'll do this several times a week and try to meet their goals. There is even an app for that, believe it or not. You can get an app on your phone and a little device that you would, I've heard you can sit on it, and it's a little pad. You squeeze and you can see, how good you're doing on your phone. So, hey, you're at the office, nobody's around, time to do your Kegels, and you sit, you do it, and somebody interrupts you. What you doing? Playing solitaire. Oh, maybe not. Sorry. All right, slide 19. Next, clicker question. Female client states to the nurse, I urinate like 10 times a day. The nurse knows that this condition is known as stress incontinence, urge incontinence, functional incontinence, unconscious incontinence. Did you say stress incontinence? That's wrong. Actually, it should be urge incontinence, because those people, go a lot. Urge incontinence, aka overactive bladder, go lots of times a day. We didn't have any indication that this person, just urinates randomly, or that they have, problem with lifting or coughing or lapping and losing urine at that point. All right. Managing urinary incontinence, slide 20. We have a couple of different options that we can give to patients. We prefer not to do the condom catheter, but that is what you see in the very top picture with a gray background. And then to the right of that would be a penile clamp. Yes, I said a penile clamp. So it's this little clamp with little foam inner linings, and you just pinch it, and it is a way to mechanically hold urine in. My first time I saw that, I said, who did this to you? I thought somebody did a procedure and left that on, but it actually stays on all the time. A person takes off the pee, makes sure the skin's okay, and clamps on, higher or lower area. Pessary is actually something that has been used a long time. You have pessaries on the right, so it is actually a ring or a certain kind of plastic device that a woman will insert into the vaginal area. Now, the bladder, you may be able to see, is supposed to be to the anterior. So it's supposed to be toward the front of a belly button, right? That's where you're supposed to find the bladder. However, after childbirth and all those muscles change, the bladder kind of falls back, into the vaginal area, which makes it easier for the urine to come out and have less control. So the pessary actually pushes the bladder back to the forward space, particularly where the sphincter rests. So it kind of gives that mechanical block. Let's see, surgery, worst case scenario, you can actually get what they call a bladder tack or a bladder sling. This is where they, for females, and you have to be done with child, bearing years. They'll do it to a 20-year-old if that's the case, but she has to make sure she doesn't want any more children because it will just undo and probably do more damage. But they'll actually tack the bladder back forward and, kind of take the stretched muscles and pull them back where they're supposed to. So the female can have bladder control. So that's a surgical intervention. Parental teaching for enuresis for children. It's a extremely inconvenient thing for the child, for them socially, mentally. They may feel anxious about using the bathroom, at other people's houses. But let them know, just communicate to the family, limit these special drinks that I mentioned earlier, not alcohol, tea, cola, things like that, so they can successfully have like a sleepover at another kid's house. So limit the fluids right at the evening, particularly the fluids that cause the bedwetting or cause the loss of bladder control, I should say. Take regular trips to the bathroom. All right, slide 21. Oh, there it is. Oxybutynin. You mentioned that earlier. Was this over the counter or prescription? Over the counter. Good. Very good. You've been listening. So yes, you can take oxybutynin. Detrol, that one is still considered a prescription pill. Sorry, I had to think there for a second. And these are anticholinergics. These prevent the spasming of the bladder. So for urge incontinence or overactive bladder, you can give them these medications. What's what I want to say? You can do a nerve stimulator. That's definitely a medical implant. I'm trying to not bog you down with too many details. I already mentioned the surgical interventions such as the sling or the bladder tack. We already covered that too, managing enuresis. And you can give the kids medications to help with bladder control, but try behavioral, always try behavioral and cognitive before you go to pharmacological. All right. Next slide.